It's September 20th, 2024, and this is the Room Now podcast. Hi, I'm Jack Cush with Room Now. I'm back in Dallas. If you didn't notice, I spent most of the summer on Long Island with family and friends where the weather is nice and wonderful. And I'm back in Dallas, and here it is, September 20th, and it's 100 degrees outside. And I like it. There must be something wrong with me. But then again, I think you may have already surmised that. So today on the podcast, we're going to talk about lupus and a lot of other topics I find interesting. Let's start with lupus. There's a registry called Pedialup that actually is a registry of children with SLE. I like this study because it gives you something, a nugget that you need to store away, and that is childhood SLE is bad news. It is way more aggressive than is adult lupus. This study of 138 children with SLE, they were followed for 15 years, and they showed that over time their sleet eyes went up and down, but in many of the patients there was a significant increase in the slick damage index. This is looking at what happens to organ involvement, including renal involvement. And by end, 34% of patients had active lupus damage as measured by a sleet eye of greater than 6 and an increased slick damage index. It was more likely in African Americans, especially sub-Saharan Africans, with a 7-fold higher risk of having active childhood SLE even after 15 years. It's a bad news subgroup. They have to be watched closely, treated aggressively, treated by someone who really knows lupus, if not childhood lupus. An interesting study this week came out of a New York surveillance registry called the Manhattan Lupus Surveillance Program, where they were able to collect data on cardiovascular events in SLE patients over time. The takeaway message in there was not surprising in that there's an increased amount of cardiovascular events in lupus. That's not surprising. But what they found was who is more likely to get it, and that is younger males, Hispanics and Latinos, and non-Hispanic African Americans. So ethnic groups we know. But another point that I always like to make is that males, especially young males, with lupus, you really have to have all the genetic, environmental, and immunologic aberrations in line to get lupus if you're a male, a female predominant disease. So males with lupus are almost as bad as kids with lupus. Something to keep in mind. A analysis of lupus patients from an academic medical center looked at not lupus so much as ANAs over time. And they found that ANAs, as you might expect, were more likely to be positive in lupus patients than in other autoimmune diseases that are known to associate with lupus, like myositis and systemic sclerosis and Sjogren's and even RA, with a 2-fold higher odds in lupus compared to those other autoimmune conditions. But this report also lays down some evidence that I've read from Peter Lipsky and David Pazetsky in that, ANAs are quite dynamic, that they tend to be highest at the onset of disease, that they change quite a bit over time, and that they certainly decrease with time, if not go negative. So the idea that, once ANA positive, always ANA positive is not always true. Something to think about. A study of 115 patients with systemic sclerosis followed over 4 years, looked at associations between clinical variables and a number of different outcomes. And they showed that the modified Rodnan skin score, which I do in all my scleroderma patients at every visit, and follow that seriously, that the baseline Rodnan skin score and the finger to palm distance were significantly associated with worse outcomes over time. that they predicted were skin outcomes. They predicted the involvement of lung disease, I think, over time, or actually that's the next study, I think. But anyway, the question is, how do you follow patients with systemic sclerosis? I think you've got to do a modified Rodnan. But they were making a case in this report for doing the finger to palm distance. And it's the distance from your distal tip of the fourth finger into the palm. Mine would be 0 because I get it right into the palmar crease. But you can measure that. The problem I have with that is, how do you measure that small distance when you can't get there? You got a ruler in there. You're getting your cardiology calipers out, and sticking the patient and getting a blood glucose at the same. It's a little awkward. Or maybe it's just a visual representation. Yes and no, or not even close. But anyway, it is seemingly a predictive variable that can be followed serially over time. Check out that citation. A recent meta-analysis looked at the use of JAK inhibitors in patients with interstitial lung disease. Does it help interstitial lung disease? And they had 7 studies, 183 patients that looked at that. But they also had a number of other studies where they actually saw what happened with if you are on JAK inhibitors, whether or not you might get ILD. So first point is that it might have been effective. And they showed in the 7 studies, 183 patients, that there was a 2% increase in FVC, a 3% increase in DLCO, 11% had improvement in their high-resolution CT scans, and 5% had worsening of their ILD. Sounds like a draw, but isn't this what we're looking at now as best possible outcomes in people with bad or just interstitial lung disease, which is largely a fibrotic condition and a damaged state that is not likely to change very much over time. And if it did change over time, we'd have a lot of drugs to treat ILD. I don't know that this data says that JAK inhibitors work. I don't think I would use this data to want to use JAK inhibitors in ILD. They found that the risk of developing ILD with a JAK inhibitor was low. It looks like 2 events per 10,000 patient years, with rates that were similar to that seen in patients who were treated chronically with abatacept or rituximab. I don't know that this furthers our understanding. I do know that this is a difficult area, and to me, treating ILD is like, is like treating ugly. I don't know how to treat someone who's ugly. I can buy them a new hat, get them a new suit, get a better haircut. Maybe some better smell might make them more attractive. But if you're ugly, you're ugly, and I can say that as an ugly person. But these are the facts, and we have to manage ugly conditions like ILD, like systemic sclerosis, like Sjogren's syndrome. And when the damage is done, I've seen the needle and the damage done. That's a line from Neil Young and the Harvest album. When damage is done, I can't necessarily pretty it up. Maybe the best you can do is fix what you can and what matters to the patient. So maybe a hat and a suit and a better hairdo. But I know that I'm frustrated and I'm not at my best when I have to treat ugly. But wait, maybe there's hope. Speaking of ugly, alopecia areata, alopecia universalis. Until the JAK inhibitors came along, there really wasn't much that worked very well for those folks. And JAK inhibitors have revolutionized that. Anyway, I'm not going to talk about JAK inhibitors and alopecia areata. I'm going to talk about a retrospective analysis, claims analysis of 63,000 people with alopecia areata and what they developed after that. And in this study, they showed that they have a 30% increased odds of developing a psychiatric illness. That happens with psoriasis, does it not? You develop a chronic skin condition that you have to live with, that others have to watch. It's hard on the brain. You know what else they get? Alopecia areata patients, they have a higher incidence, a 2.7-fold increased odds of autoimmune disease, led by lupus. hazard ratio 5.7. Atopic dermatitis, hazard ratio 4.3. Vitiligo, hazard ratio 3.8. Sjogren's 3.7. Morphia 3.6. Psoriasis 2.8. RA 1.8. And there's a whole bunch of other ones. Check out the citation. So, and we know autoimmune disease runs with other autoimmune disease. But, I also think of alopecia areata as a skin-only condition. Maybe that's not the case. This week, a big new regulatory announcement. The FDA announced approval of Fasenra, that's benralizumab, another anti-IL-5 monoclonal antibody. This one's made, I think, by AstraZeneca. And it was approved for use in the treatment of eosinophilic granulomatosis with polyangiitis, EGPA patients. The approval is based on a fairly large head-to-head trial, the Mandara trial, head-to-head of benralizumab versus mepolizumab, showing that one was non-inferior to the other, both achieving remission in about 60% of patients. So now you have another IL-5 inhibitor for the treatment of patients with EGPA, and I think that's good news for a condition that's hard to treat. Getting off the drug track, what about natural products? We don't talk enough about that. 40 postmenopausal women were treated with black currants or placebo. Black currant therapy, what's the endpoint here? I think it was 14 weeks, I'm not sure. Lowered IL-1 beta significantly and rank ligand, and was inversely correlated. The BMDs that were seen in these people were inversely correlated with changes in rank ligand. So maybe there's a benefit to black currant therapy in patients with impending osteoporosis, osteopenia. Black currant have this bone protective effect. What's the mechanism? It could be through IL-1 and rank ligand. They also, in this report, provide some evidence showing that it changes the gut microbiome. And that could be another role for this. I could probably spend a few weeks just covering the benefits of berries in treating inflammatory disease. I've talked about tart cherries in the past and gout, but blueberries and all berries, they have significant anti-inflammatory effects, and that includes COX-2 effects, and they have other effects that are certainly very basic immunology kind of effects that would benefit many of the conditions. So I encourage my patients to take these, and I don't think there's a downside to it. Can you space out injections with biologics? We think we can, especially in people who are well controlled. But there's actually a trial that was done in patients with guselkumab. I think it was called the GUARD trial. I don't know the name. It's a phase 3 trial of patients who were treated with active plaque psoriasis with either placebo or standard doses of guselkumab, which was basically injections every 8 weeks. At the end, patients who were in good shape with a PASI score of less than 4, so 3 or less, they were randomized to continue on at Q8 weeks, or they could be spaced out to Q16 weeks. And when they followed them out for another year or half year, that one was non-inferior to the other, meaning that maintenance of super response, and they call these people super responders based on what their PASI scores went down to, was maintained at over 90% with both regimens, suggesting that yes, if someone is a super responder to guselkumab with psoriasis, you can space them out. I'd like to see this kind of evidence for all the biologics we use, but I'm putting it up because we don't really see enough of this. A Swedish registry study looked at the incidence of psoriatic arthritis and found that to be 22 per 100,000 patient years, higher in females, higher with low educational levels, peak incidence between 50 and 59 years of age. The interesting point on this study from Sweden, where they collect really good data, was that 71% were on a DMARD within 2 years, and that 22% of those patients, 1 in 5, were taking either a biologic or a targeted synthetic DMARD. Should it be higher? Were they doing better than you, or are you doing better than them? I think the challenge is in identifying these patients and getting them earlier. By the way, that's my solution to treating ugly. Get me when they're really, really young. Get me when they're brand new in their diagnoses. Then I can change trajectory. Then I can avoid damage. I can avoid ugly. Getting these patients early, I think, is the key to better management of psoriasis and psoriatic arthritis. Really interesting report this week that kind of breaks one of my teaching myths, and that is the diagnostic value of inflammatory back pain in diagnosing the spondyloarthropathies. Well, in this single center study, I think over 10 years, they collected 34 cases of patients initially diagnosed as a spondyloarthropathy because they presented with inflammatory back pain, but they didn't have SPA, they had cancer. What? Cancer masquerading as SPA? How's that possible, Willis? Well, these patients who did have cancer had maybe higher than expected levels of acute phase reactant, sed-rate, CRP, but also LDH. What kind of cancers did they get, you say? You ask? Multiple myeloma, acute leukemia, lymphoma, breast cancer, lung cancer, prostate cancer, bone tumors, and a few rare ones. It's possible. Don't close the door just because you've seen inflammatory back pain. Still's disease is in the news again. A trial of IV tocilizumab where 62 patients with systemic JIA were treated with about half with either 12 milligrams per kilogram. 12 milligrams per kilogram, really? Yeah, it's in the package insert. Or 8 milligrams per kilogram. By week 12, 87%, basically everybody, responded with a JCR 30 and no fever. Basically, they treated systemic disease and their arthritis got better too. The results at week 52 were the same as the results at week 12. I think this is good news. And the other good news is that there were no cases of macrophage activation syndrome. I'll remind you, there was the pivotal trial of tocilizumab for systemic JIA was the TENDER trial. I want to say it was over 200 patients, 6-month outcomes. In that trial, even though systemic JIA patients were being treated with tocilizumab, the IL-6 inhibitor, I want to say there were either 3 cases of 3% who developed macrophage activation syndrome. So while treatment of macrophage activation syndrome would be the initiation of either an anti-IL-6 or an anti-IL-1 along with steroids, that it can happen on both those drugs. So you're not scot-free. What if you do get macrophage activation syndrome? This week published the REAL HLH study, a retrospective experience with emapalumab, the gamma interferon monoclonal antibody drug approved for use in HLH in all its forms. This particular study showed that it was effective in 15 rheumatic patients with HLH or MAS. 2/3 of them had Still's disease. 60% were in the ICU at the time of treatment. Well, they all had refractory disease, and that's why they received emapalumab. Emapalumab normalized CXCL9, the chemokine that is a surrogate marker for gamma interferon, normalized the absolute neutrophil count, lowered steroid doses significantly, and had a 12-month survival of 87%. These are impressive numbers. I have not yet used emapalumab in treating MAS and Still's patients. I will when it comes up next. Again, MAS, HLH, has a high mortality rate, as high as 40% in both kids and adults. Three more reports, 2 on treat earlier. One I found interesting, and Kevin Dean had suggested to me, Kevin's like the maven on preclinical RA, clinically suspect RA. We talked about at a Yale meeting recently about is it cost effective to use these expensive therapies in those patients when we don't really know quite the true outcomes? And he said they're doing an analysis of their experience, and then the Treat Earlier people just published their results of cost effectiveness in the Treat Earlier trial. As you know, a 236 patient trial done in Europe where they had clinically suspect arthralgia and no swollen joints, but they had subclinical evidence by MR ultrasound of some synovitis, and they were randomized to receive methotrexate or not for a year, and they followed them for 2 years afterwards. They showed that in 1 year of methotrexate was cost effective, both by methotrexate increased the quality adjusted life years, and reduce the overall cost with 1 year. I think that's really big. If you're looking for a reason to not do it, maybe cost is one reason. But now they're just looking at methotrexate. What about if you did this with biologics like abatacept? We need to see those analysis. Another report, this one was from Lancet Rheumatology, about where is the confusion about treat earlier. As you know, it was a methotrexate intervention trial. The primary outcome was the prevention of chronic inflammatory arthritis, or RA, with time, and it failed in its primary endpoint. But the sub-analyses showed that it worked on pain and HAC and a few other things. So there's some confusion. In their analysis of the data, they showed the people who did respond to methotrexate were the EGPA negative, not rheumatoid factor, but EGPA negative, right? Those were the ones that were more likely. So 236 people, and of the ones that were enrolled, 3/4 of them were EGPA negative and 1/4 were EGPA positive. If you were EGPA positive, it didn't matter. Your odds of developing RA were the same, about 21, 23%, if you were treated with methotrexate or placebo. Odds were the same, suggesting no benefit. But if you were EGPA negative, they then subdivided those people into those that were at an increased risk or at a low risk if they were EGPA negative. If you were at an increased risk based on a Leiden risk score, and those are risk of progression, having more things that would make it more likely you're going to turn into RA. People treated with methotrexate had a 9% chance of developing RA, whereas those on placebo had a 29%, and that was significant. And that was an overall reduction of 73% in the odds of developing RA. However, if you were EGPA negative and had a low risk, you had none of these other risk factors by the Leiden risk score, the odds of developing RA were the same if you were on placebo or methotrexate, 8 or 10% on placebo. So therein lies some of the message. If you're maybe a clinically suspect arthralgia-only patient and you're EGPA negative, but you have many other features, maybe giving methotrexate might make some sense. I like the analysis here. Lastly, I'm going to end with the Foremost trial, which was published this week about apremilast, and is it appropriate in patients with early oligoarticular psoriatic arthritis. This was a randomized controlled trial where patients received either placebo, 308 patients with psoriatic arthritis, and you had to have mild disease, only a few joints, relatively early in the disease course. And yes, 40% of these people were taking another background conventional DMARD, and they had either apremilast by itself or apremilast plus the conventional DMARD, or maybe they washed out of the conventional DMARD. I don't know. But the bottom line is that using a modified, a minimal disease activity response, and it was actually modified for the number of joints at inclusion, meaning they only included people with 3 or less joints, for instance, that an MDA response, a superlative response, was more likely to be achieved with apremilast, 34%, than placebo, and that was about 16 to 8%. And those numbers were very significant at p.003 or less. So again, I think this is important. And other outcomes also were better with apremilast in this population, including PROs, other disease activity measures, and skin measures when using placebo. Right now, it's not in the package insert that says it only works in early disease or mild disease. But yet that's always what we talk about, right? Well, you use apremilast in people with mild PSA. Well, no, you don't. Not until this study, the Foremost study. Now you have proof that you can use it there. But the drug, as approved, was studied in people with polyarticular psoriatic arthritis, well-established psoriatic arthritis. And you know what was mild? Their responses. They had ACR 20 responses of 40% or less. And it was a little bit better than placebo. So a very safe drug, very well tolerated, sometimes gives you a really good response. But that 40% ACR 20 response could have been a mild response, or it could have been done in mild people, could have been done in really severe people. I've done treated a lot of patients in clinical trials with apremilast, and I've seen fabulous response in people with 13 swollen joints with psoriatic arthritis. fabulous response to people with 4 or 6. So you're not really limited is what I'm saying. But here, if you really need to go by this rule of early and mild, boom, the foremost study is your proof that you're doing the right thing. Up until now, you've kind of been misreading the data or listening to other people with the wrong message. I'm going to end with a quote I heard this week at a workshop I was in. Big doors swing on little hinges. As a little hinge in this world, it gives me hope. Tune in next week for the podcast. Take care of yourself.